So I am going to be talking about PSA screening and just what I call the staggering benefit. I was staggered by it because I was just trying to sort out this whole mystery of PSA, and of course, a lot of us kind of take at face value the task force recommendations, and even if you dig a little bit deep and say, wow, this is a very flawed study that becomes the basis for these recommendations, it stops a lot of very smart people in their tracks. And I know Alan Lichter was head of ASCO for 10 years, the head of ASCO, and this literally drove him crazy, that this stood, because it just seemed like a very bad policy on thin ice. But so my collaborators on this are Payal Soni, Alex Sodikoff, Juanita Crook. Alex Sodikoff is the one who was the first author on the CISNET review in the Annals that kind of pooled the PLCO and ERSPC studies. It was recently and showed a 30%, kind of pooling them, you could show a 30% mortality reduction. So this is two conversations that should never have taken place. I have Tom, this is a patient I met several years ago, 58, and both of these are extremely intelligent men, but he was diagnosed with T3B, PSA 11, Gleason 8. Years before, he had a conversation with his doctor, very well read. I mean, he has his own website now, bemoaning the fact that he kind of listened to the task force, but he was quite cynical about doctors and biopsies and the racket he perceived. And, so his diagnosis was actually, you could look back, and it was delayed at least 5 years. And we gave him very aggressive treatment. 4 years after that, he developed metastasis. So I think this was an avoidable disaster. I don't think he would have ever landed in this condition even 10 years or 15 years before that. The next guy, I gotta really say this was even worse. Frank, who's a guy I had treated 5 years earlier with very aggressive cancer, and I gave it the whole, combination, the whole works, and he came in at 5 years, and he was actually miffed because there was all this stuff in the paper from the task force saying there's all kinds of unnecessary treatment for prostate cancer. And here he's got one of the worst cancers you could have, and he's miffed, and he said, from everything I read, I should never have had treatment, right? So these guys are both smart, right? And there are a lot of people in all of our fields that are smart, but they were kind of, if you say one thing about the task force, you might disagree with everything, but the effectiveness of their messaging is staggering. How many think tanks in the universe kind of put out directives and completely sway the world like they have? And so they're doing something right. Unfortunately, their message is wrong. But how do we reconcile mortality reduction? Because that's really their ticket to ride on this negative message, right? They perceive 0% mortality reduction. They use the PLCO to their advantage there. And then there's little inklings of this and that and different mortality reduction. So what we were looking at and what we started with is what I call the mass deployment. So some of the terminology I'll just explain, but the mass deployment we just say is flooding of PSA screening in 1990. It's almost unbelievable the degree in the US, right? I mean, millions of men, probably half the population within 10 years at risk were screened. I'm not even sure what was driving it, but that was a mass deployment, almost a military operation. And about 15 years in, 40% mortality reduction was noted. But interestingly, at that same time, only 50% of men had been screened. So you kind of do the math, right? 40% reduction with 50%, what would it look like if 100% were screened? You would say 80%, right? So suddenly you have this absurd, what I would call an absurd mortality reduction right in front of your eyes that you have to explain. Because to drop a whole population 40%, the guys who got screened had to be 80%. So it's really simple math, but it's, that's the part that's, if that's true, then it really blows up the whole PLCO 0% mortality at 15 years. So how do we reconcile this? Well, we have to look at the population deployments here and in Europe. I won't be able to do the European one. They had sort of a slow burn. They did not have as interesting of like a mass assault like they did in the US, but it's still a huge factor. It's sort of a population effect. Then the controlled randomized trials, there are some really, really fine trials, the ones you should read about, and then the summation of the population effect and the randomized trials. So here's a very Sesame Street slide at 15 years, right? You had 50% screening penetration, 40% mortality reduction. What would it look like at 100%. So that's our arrow. Then the mortality reduction on the randomized trial, very different shape, right? That first one was a demon drop, right, from mass deployment. But in controlled randomized trials, what was confusing is that there's a long period of quiescence before you see any change in mortality, because you're pulling guys out of line who are destined to die 10 years down the road or 15 years down the road. You're sort of finding them, pulling them out of line, and so they don't show up to die for 10 years when they would have. And so if you see a difference, there's this 10-year gap, and this is true in all the controlled randomized trials. It's kind of interesting. And then you see the reports. At 15 years, you see a 50% reduction in some of these trials, but you have to kind of figure that 10-year waiting period out a little bit. So then one lead time, again, I work with Alex Sodikoff, who's an incredible statistician on CISNET. Everyone in CISNET said he's the smartest guy. But, when you talk about lead time, and I always think these are abstract kind of calculations, and I know what lead time is, but I sort of want to see it with my own two eyes. So there was an interesting study of 20,000 physicians in the late 80s where they had given a blood sample in 1982, and then they went on to whatever they went on to, right? They're older population, and some of them had heart attacks. They looked back at their cholesterol. Some of them had prostate cancer. They looked back at their PSA. So what they found is that for the lethal cancers, that blood test, this is one PSA, this is not any kind of systematic, right? 1982, they have the serum from 82, they run the PSA and said, we could have known your lethal cancer 3.5 years ahead of time, we could have known aggressive cancers 5.5 years ahead of time. So this is not abstract lead time, this is actual lead time, and there's nothing controlled about it. So we draw the arrows to say that could be way better, and a lot of people say you can get a lead time of 15 years with screening timed right. So there you have some kind of high impact effects, but kind of lay of the land. So we're going to start with the mass deployment. Again, what we have though is we have an observation trial, right? We're all trained. This is an observation trial that wasn't even a trial, the mass deployment, but it had millions and millions and millions of men. And then you have a controlled randomized trial, which is legitimate, right? That's the first thing we learned, even though the controlled randomized trial is flawed. So you have millions of men screened. Spike and drop in incidence was unique to the US. There's a Stamey effect that I'll describe and define that I think is the most interesting man, no question, a colorful, interesting man, no friend of radiation oncology, but his papers are so great. And there's one that I think is going to end up rising to the top. But rapid effects, right? No 10-year delay. It's just you don't have to look that hard to see what was going on. So the incidence curve from the mass deployment, you see this famous spike and drop, and then shifting from there. So the spike and drop is interesting because for the most part, people use that to say, look, at screening found all these meaningless cancers. We wish we wouldn't have found them. It just gave us all kinds of diagnoses. But then look at African Americans, and in that spike, you can see a doubling of poorly differentiated cancers. And in fact, if you go back even a year or two earlier, you can see a tripling of finding poorly differentiated cancers in that spike. That is gold, right? That's what you want to find. Not at a clinical stage, but in the whites, it was 1.4 times these cancers. Then you have a plateau and a decline, and there was a decline in incidence even before the task force. It was kind of, PSA was sort of being debated a little bit. You could almost feel it. Suddenly you weren't seeing as many. But the Stamey effect, this is a paper that I think is so interesting. In 2005, in writing for 2003, he wrote, the PSA era is over. And basically the tap is dry. I mean, it's almost like he had almost a monetary business. How am I going to fill my operating rooms, right? He said in his district, a very wealthy district, if you had an elevated PSA, you had BPH, there was no more cancer left. I mean, it was sort of like so screened. But, I think the PSA screening, the fact that PSA screening can completely deplete a population of prostate cancer lethality is fascinating. I mean, that is absolutely, in 10 years. So I think he wasn't exactly on cue for what was going on in the bigger sense of how momentous that was. But that shows you this mass deployment, probably taken to some absurd degree in a wealthy community. They might have been getting their PSA every 3 months, who knows? But they found all the cancer in 10 years. And then, he wrote about it. His really incredible force in oncology. So in a little over 10 years, the population was utterly changed. Now think about this, a randomized trial done where Stamey lived would have been absolutely negative. There's no more lethality to find early, it's gone. So what I think we have to kind of reckon with here is in all of the places that these randomized trials were going on, you had this sort of dropping lethality in the population. Wherever there was really fervent screening, and I can remember, God, my practice, it was absolutely crazy, the number of cancers we were seeing. But you have to kind of see that as a population effect. And then look at the PLCO accrual. The PLCO accrual starts after the spike. And in some places, it's going on while that drop is probably going on. So think about that. What do the people, I mean, we can check with local authorities, but you know, what do they say about the PLCO? We just didn't find the lethality we thought. We did not find as much mortality as we thought we would. And I think the clue is right here, that there's this Stamey effect, this population screening, a fished out pond, if you want to think of it that way. But what about the effects that matter? Well, this is what I mean by rapid effects. This is a paper from 1991, the heyday of the start to 99. There was a 65% drop in METs at diagnosis. So early on, before the clinical era, there was 20 to 25% of men walking in with METs. So imagine 8 years later, that's 65% down. You're finding them a year or 2 or 3 ahead of time, and that lead time, even if you give them the lousiest treatment on earth, can still buy them a lot of time. Once you get to METs, it was sort of like the clock is 4.5 years at that time. What about mortality reduction? Well, 27% in 8 years, first 8 years after that. That's nothing to sneeze at, and that's not even a finished story. So if we look at it, it actually makes sense, right? The METs at diagnosis drop, and then in a staggered way, you suddenly have guys not dying that would have died, right? And if you just project this out with the dots out to about 2003 or 4, then you get to that 40% drop. But remember, this, you know, just hold this slide in mind. We'll come back to this at the end. This is with 50% screening. Massive, impressive drop in mortality. So now we go to the randomized trials, and there you have a challenge. 2 major limitations are contamination, that guys on the control arm were screened, non-compliance, screened arm were not screened or didn't get biopsies. The PLCO, believe it or not, 40% of men with a high PSA that met threshold did not have a biopsy. In the European trials that were positive, it was like 90%. If you hit threshold, you had biopsy, but you had a conversation in PLCO. And it's only 40%. So how do you call that a great, you know, PSA screening test if you're leaving it up to someone whether to have biopsy or not? Some trials had sufficient data to correct contamination and noncompliance, Göteborg and Rotterdam, and those are the ones I hope I can convince you to pull the papers and talk about. Some trials completely were undermined by contamination and you really couldn't correct. So on the PLCO, the control arm did as well as the screened arm, and control arm had 90% screening. So we have to look at some of these others. This is a slide for the ages, to my mind, as I finally dug through these things. This is a summary of all randomized trials, and so if you want to say randomized trials don't show a mortality reduction, you have to kind of go through this gauntlet. So PLCO is 0, and I don't have an arrow here going down that it could be improved because it would be impossible to get rid of the contamination and the noncompliance. It's literally, it's a uniform screening, 100% screening trial. ERSPC, 21% mortality reduction, all kinds of problems. That's really a pooling of seven trials, and with very different quality and endpoints. Then Rotterdam, though, Rotterdam and Göteborg were both in the ERSPC, but they had exceptional data management, and they were able to correct for the 2 big Achilles heels. They were able to correct for
contamination, noncompliance. So Rotterdam, 32% mortality reduction straight up, but if they corrected for noncompliance, it was 51%. Göteborg, 44% mortality reduction straight up. When corrected, 56%. So we're not at 80 yet, right? I said it's going to be 80%. But if you look at Göteborg, what they did was ingenious. They had these slots. They had ages 50 to 55, 55 to 60, 60 to 65, and they sort of tracked those. Now, the nice part about Göteborg 2 is it took 10 minutes to enroll the patients on it instead of 10 years, right? All they did is pull 20,000 names off a registry. So it wasn't, and there was no consent. It was just this incredible, not even sure you could pull it off today, but immediate, you're on board, you're not, and they had great compliance. But in the group that was 55 to 60, when they corrected for, even without, 61% mortality reduction with all the bugs and all the problems. But when they corrected contamination and noncompliance, that went to 78%. So again, this is a randomized trial, hit the age group right, and you're 80% reduction in mortality. And yet people are quoting that 0% PLCO as if it means something. So this, you have to kind of, whenever you have a chance, knock down that idea. But it's very interesting, the mortality reduction, because it tells us something. Not only do you have this mortality reduction, but if you look at the group that was 60 to 65, it's only down 27%. And a whole bunch of those guys at their first PSA screening already had metastasis. So they're not only telling you there's this incredible effect of PSA screening, but they're giving you the window. They're saying there's a tight window, and we kind of combine that with some of the other PSA threshold. Göteborg had a 2.5 PSA threshold, lower threshold, younger men, younger age at diagnosis, big bang for the buck. So this is how this looks. Now the last staggering point about these randomized trials is they're at 15 years, right? So that sounds mature. But if you look at the control, guys on the control arm, the actual average follow-up for patients on the control arm is 4 to 6 years. And the average for the screened arm, caught earlier with screening, is 6 to 8 years. So how many of you believe that 4 to 6 years the story is in on advanced bad prostate cancer? So we know there's going to be a fanning out, and this is going to hit 80%, probably year 20, who knows. But it's a very impressive effect. And if you put 78% in here, there's going to be like a sweet spot where you can pretty much prevent almost all prostate cancer mortality. So if we go back to our mass deployment and we say, how do we fill in the dot? How do we know what would happen if 100% were screened? Just look at the PLCO. Put the 100% screening arm in, and this is the mortality, and it's down 65%. But that was not a perfect study. If you look in Europe and compared to ERSPC and the 100% control arm, it's 80% mortality reduction. So I wasn't kidding when I said there was an 80% reduction in mortality if you look in the most accurate way at these studies, and you have a control. That these all came right after a clinical era of PSA diagnosis that is horrible, and we're starting to see it again. I am really saddened. So here's the slide that I would have to say threw me completely out of my game. My game has been, I'm a Whitmore guy, right? You basically said what's going to make the world a better place is it's not going to matter to screen people because none of our treatments cure them. Until we get curative treatment for advanced cancers, it's not going to matter. That would have been me. I've spent my whole life trying to gear up, crank up the intensity of the treatment to get a better control rate. But this was the hardest thing to understand for me or believe and even to acknowledge. So this is observation of poorly differentiated cancer. The Albertson trial, the Albertson study you always look at to defend active surveillance, has a group that were poorly differentiated, and they watched them, and there was 80% mortality at 10 years, and that the black is prostate cancer mortality. So this is a kind of a classic clinical diagnosis, bad cancer, and at every age group, prostate cancer mortality is greater than non-prostate cancer mortality. So this is what none of us have as a reference for how bad this stuff is if you don't find it. But that's a nice reference. Now we look at a contemporaneous RTOG 9202 trial right in the heyday of the screening, right? Dr. Lawton just presented this. So 20-year follow-up of this 9202. And I remember reading this and thinking, this is the most depressing thing I've ever read, because by 20 years, either you were dead or it had failed, but it was just crazy bad, the failure rate, right? It's like everyone suspects with beam radiation. You're not doing anything except watching this failure. But what do you notice? So here, this is 90% clinical failure. I pull that out, but look at what's happened to the mortality. Only 20% of the patients on that trial died of prostate cancer. So how do we put this together? You get that lead time, and you get the 10 years, 12 years delay time of non-curative treatment, and suddenly you have eliminated mortality from prostate cancer. So it's a staggering fact to me that, and Whitmore would have turned over in his grave to know this, because he would say until you get a curative treatment, you're not going to get anywhere with this. But when you actually look at that lead time, what we were probably getting in lead time was 10 years delay time. Suddenly you've bought 20 years of sort of prostate on the back burner. Now, finally, though, Whitmore would have been very happy with this. Okay, this is the JAMA that says 87% for the most lethal cancers, 87% no mets at 10 years. So now we can say if you have bad cancer, if you need curative treatment, you can cure it. So to go through this, and how am I doing on time? Sorry, I'll just race through. Oh, okay. Oh, okay. All right, thanks. So I'm going to go through how I think this works. This is, instead of grading screening, which is, I think, a crazy, absurd thing, screening does nothing, okay? It just gives you opportunity, and it's better to talk about screening range. So this is the natural history of prostate cancer, and how early can you find it is the screening range, and how late can you treat it and cure it is the treatment range. So you would say the overlap of those two is a curative range. You find it early, you use a treatment that will cover that, and you're okay. If you look at DRE, why that was such a non-interesting time, because you had to have palpable disease, and so the range was limited. You couldn't find it early, but the treatment range was also limited, so your bandwidth for cure was very limited. But as I just said, we don't need to cure, we just need to delay. So if you get PSA, suddenly now you're in this really different bandwidth where you're finding non-palpable PSA producing disease. You're finding it earlier in the natural history. Curative treatment range has increased. So we have a limit though, and we know that 10% of men die of prostate cancers that don't make PSA. So the only way we're going to find them is with MRI screening, and lucky for us, you can do MRI screening with a non-contrast scan, probably in 20 minutes, and that's going to be necessary to find these. But what you find then with screening is you have an opportunity for cure for all these men. Screening gives you an opportunity. It doesn't do anything if you don't treat, and you don't treat aggressively. For most of the time we had these opportunities for cure, we met them with remission therapy, and that did a hell of a lot. But now we have very curative options. Then for these are not curable in our current era, but there's an opportunity for remission. And remission, I just mean you're not curing, but it holds it in check for 10, 12, 15 years, and that's all you need at that age. And then finally, palliation only for these. So what do we want? We have an opportunity for cure. We want to cure these and prevent metastasis. Mortality is the easy hurdle to get over, but we want to find all of these guys early, do metastasis prevention, and then for these, the game is delay, delay, delay. There's incredible agents now that'll help you keep them from dying of prostate cancer. So how does it work? This is a timeline in a patient. You could call this mortality or METs, whatever you want to call it. This is lead time. They're caught early, and lead time does nothing. If you just find them and let them go, they're going to die at the same time. So screening does nothing. Don't grade screening. It's ridiculous to grade screening. So if you catch them early and you give what I used to think was terrible, absurd, miserable, meaningless, ineffective therapy, you might still delay their mortality enough that they die of something else. And so that's success, right? And then finally, in the current era, if you find the same destined to die here with metastasis, if we call that, then you cure them and you prevent not only metastasis but death. And so very different, this is a very different picture than I would have pictured looking at this. And Alex Sodikoff kept saying to me, you know, whether you cure or whether you control, the treatment doesn't matter, the treatment doesn't matter. And, you know, I'm saying it's got to matter. We got to give them combination. We got to cure them every time. But in reality, for those young men with horrible disease, you got to cure them. But for a lot of men, it turns out the mortality was absurdly dropped with that. And so now if we look at just the policy side of this, this is a domain map where you have a screening domain, treatment domain, palliative domain, and this is the population. You have non-lethal prostate cancer. I agree, we would like to not even find that, right? We'd want the block here, not even screen for it. This is potentially lethal prostate cancer. You can screen, treatment. We want to stop these guys before they get to Mets, right? So if the task force gets its wish, you sort of stop screening. You definitely stop finding these guys, but you have just opened the door for guys to progress to clinical stage. And what's the problem with that? Whatever the reason was that they went that way, it could have been, you know, you don't know. I mean, no one can figure it out because they say insurance companies got their, you know, said we can't afford to treat all these guys. But it's almost the greatest irony in the world, because even if you were trying to save a few bucks not screening these guys and not treating them, the cost for these drugs per patient is $500,000 in the US. $500,000, $200,000 in Canada. Juanita Crook thinks that's a lot. I said $500,000 is really a lot. So you can kind of take your pick. The cost of treating 30,000 men with palliative drugs eats up the entire budget for genitourinary cancer, like $15 billion. Or you can screen, you could even do MR screening. It's like a cost-effective thing to do is find these early and treat them, and you'd have money left over for better uses. None of these guys who progress to these costly drugs is going to be cured. None of them is going to be happy with the time you save for them. And so I think in conclusion, PSA screening can reduce mortality by 80%, as evidenced by mass deployment and the controlled randomized trials without contamination and non-compliance. Much of the mortality reduction in the 1990s was due to a remission effect, which is lead time plus delay time from non-curative treatment. That, to me, is so interesting. In a modern era, intensive screening can allow early enough detection to provide an opportunity for cure. Curative therapy is now available. That JAMA paper for Gleason 9 and 10 that says 90% no Mets at 10 years tells us that you kind of Whitmore got his wish too, right? You find these terrible ones and you can cure them almost every time. The task force has elected to solve overdiagnosis and overtreatment, a worthy goal. I mean, I totally am on board with that because lots of lives have been ruined, but for no good reason, at the expense of life, by minimizing the mortality benefit. And their famous line is, the 3 largest randomized trials show a modest reduction in mortality. The 3 largest trials were all so contaminated and so ineffectively run. You couldn't stop people from screening in that era, so it's not no one's fault. It's just they don't answer the question the way the better ones do. Selective science is bad science, and thank you so much.